It's our second guest lecturer here, who is Vikki Small. She is the program manager of medical PCMH, which is the patient-centered medical home here at University Hospital at Downstate. She is a patient access manager. She handles everything with regard to patient, experience in the ambulatory care setting. So, without further ado, she could perhaps also give a little overview of herself. She actually took the course last semester, not for credit, just because she wanted to relearn evaluation. She already has an MPH, but she was excited that she was applying for the doctoral program, which she actually was accepted to, so congratulations. She will be starting our doctoral program next in the fall. So without further ado, Vikki Small will talk to you all about colorectal cancer screening, a new initiative that's integrated into our EMR system.
Yes, I'm Vikki Small. I work in the ambulatory care department, and my role and responsibility is to oversee our PCMH, patient-centered medical home program. It's a set of standards that we have to abide by for an enhanced rate from Medicaid to make sure that our patient care is coordinated. Our patients are being taken care of to a certain standard. As part of this new role, I understood that our care coordination standards weren't up to par and that we needed a lot of work, and I wanted to look at it. And so care coordination really deals with referrals. How do you manage the patient within the institution and also with providers outside the institution? And so I took it on. The cornerstone of referral process, or should be, is the EHR. So how do you use that system to make sure that patients get where they need to go? And so when I looked at that, I found some deficiencies there. So today we'll talk about colorectal, CRC is colorectal cancer disparities for Afro-Caribbean Black men, and I'll tell you why. Of course, this institution serves a mostly Black, mostly West Indian population, 78%. And we're going to talk about what system-level barriers we have here with colorectal cancer screening, and some strategies that we employ to improve the EHR. And then we're going to talk about patient-centered interventions and some other strategies to sustain this program. So colorectal cancer is a progressive disease. It starts out as a polyp or an adenoma in the colon, and so cancer starts as an adenoma, non-cancerous. As you can see, it progresses. If it's not removed, that's when you have the cancer. It's the second leading cause of cancer in the United States, and it's also rising in young adults. And the good part of this is that early detection matters. It improves survival rate. So screening is important in managing this process. Colorectal cancer is an issue in the Black community, Black adults, but the burden is on Black men who, if you look at the green here, outpace other races in colorectal incidence as well as mortality. And so this is one of the reasons we focused on this population. All right, so before today, how many of you were aware that colorectal cancer is rising in young adults? You heard about it? So many of us didn't understand that or have any contact or idea about that until Chadwick Boseman died at 43. He was quite young. He was diagnosed, I guess, at 37 and thought it was stage 4 cancer. This population is the fastest rising of those who are getting colorectal cancer. There's nearly 20,000 cases were projected for 2023, and the mortality is rising over time. The recommendation is that now, because of this growing population, the recommendation is that at 45, adults start getting screened every 10 years for colorectal cancer. Based on your history and the results of that exam, they may lower it to 3 years, 5 years, whatever that your physician decides. There are several ways to screen for colorectal cancer. So you can do a home test, which is stool-based, and there's also the colonoscopy. There's various kinds of colonoscopy, but the colonoscopy is the gold standard that detects 95% of cancers. And what happens is the physician goes through with a scope into the entire colon and looks for any polyps that are there, and they can immediately remove them and then take them to test. The procedure is about 30 minutes. You go to sleep and wake up. And the hardest part of this procedure is that you have to drink a prep solution and clean yourself out before the procedure. But other than that, the actual procedure is harmless. It's painless. There's no blood, nothing like that. And so these are the recommendations. So at Downstate, we offer the two. It's the stool test and the colorectal. So again, we focused on this population because of the higher rates of colorectal cancer. Also because we realized that within the data that we're saying are Black men, we realize there are populations within that. Those of us here on the ground working in this community know that it doesn't tell us everything. So we know that there are subpopulations within this group that are more prone because of barriers, social barriers, economic barriers, other things, other cultural factors that prevent them from getting the care that they need in this regard. So we all know it's no, 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 no. So that's what we say when you ask, a lot of our patients, would you like to get your screening? No, 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 no. They are not into anything to do with the rectum, whether it's prostate cancer screening or colorectal cancer screening. No, 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 no. So the stool-based test is a good alternative, although it's not as effective as a colonoscopy would be. So when I approached this, I got a team together. We looked at this, and I realized that system-level fixes was where I needed to go. I understood that the referral process was broken, that they had tried to install the referral process in our EHR. It's within the EHR, but it just wasn't implemented well. I didn't know at the time what that meant. I was had trepidation about that because if they've done it 3 times, then what was I thinking? But I thought it was worth looking at to see what was going on with our referral process. And then I used the colorectal cancer process as a pilot to see what gains we could be making that particular population, and then whatever we learn from there could be spread to the other services that use the system. So phase 1 was the EHR optimization, and here I'm showing you the red is Central Brooklyn. That's where the majority of our patient population comes from, 78% Black. And so the goal was to optimize EHR workflows towards a closed loop process. When you talk about a closed loop process, that means that I, the PCP, sent my patient to you, the specialist, you saw my patient, and you sent me back the report. That is a closed loop. That is ideal. It doesn't, what's the matter if you can't get the report back, right? So, and I use Lean Six Sigma to do this. Lean Six Sigma is an approach in performance improvement, and so that was how I approached this. Now, the barriers that I found was there were no standardized workflows. So, doctor sees patients every day. There's a clinical workflow. When you went into the EHR, it didn't necessarily match what people do in real life. It wasn't adapted for real life situations. The templates were confusing. Things were repeated. Certain things didn't function. I found that some docs had different access than others, so their referrals were actually supposed to be inpatient referrals, so it wasn't landing anywhere that anybody could even find them to work on them. There was no communication between the primary care physicians and the GI physicians, because that's what an EHR does. It helps you to communicate, and that wasn't happening. There was no process on either side for them to even know when a referral was made and all of that. And so ultimately, patients fell through the cracks. So there was no coordination there. So if you look here to the right, this is the IHI, or Institute for Healthcare Improvement. That is the model. The best practice is that all of these functions happen for a patient to be seen by the specialist and the report to go back. So I made some X's here to show that most of this wasn't really happening in the EHR. The importance of the EHR is, we all know, we all use that, right? But it really is about tracking. It's really about trending. It's really about data analysis. If you can't do that, you can't really take care of your patients as well as you should. And we were really working on a paper-based process because providers could not figure out how to use the system, and so they did what they could with the paper. And so I would ask you, what do you think the most significant barriers to colorectal screening are for Afro-Caribbean men? Natalie?
The no.
No, no, no. And why would they say no, no, no?
Well, it's a stigma attached to Caribbean men on a whole, that sacred ground.
It's
Let's
sacred
call it
ground.
that.
I'm not a man if you do that, right? That's
Right,
that's
you've
the
taken away something from me that's valuable.
right, right. Anything else? Maybe lack of education about what the process is. Maybe not having enough money because you don't have insurance to get the procedure itself. So again, went on this journey of, digging through what was going on. And so, yes, there was a lack of tracking, inconsistent documentation. And so the goal was to redesign and see how we could make it work. And so that was getting together the folks who use the system or don't use the system and find out what their barriers were. So I did interviews with providers. I sent out a survey and talked to IT. So it was really multidisciplinary, this approach. So we ultimately decided we made some changes in the system so that things flowed better. It was very minimal, but enough to make a difference for the providers who had to use the system. It was contributing to provider burnout for them to have to use the system the way it was. And we created a special template so that they could, write exactly what they needed to write for this particular procedure, which made the quality of data better. So you see here on this graph, this red line is the intervention before and after, and it worked. You had maybe the average of 50 referrals in the EHR before the intervention, and then it tripled after, and it sustained this at this level. So what that indicates to me is that, again, paper was being used, but the patient was losing the paper on the way to GI, or the physician would have the paper and they would scan it into a system that GI wasn't looking at. But now everybody's on the same page about what needs to happen with the referral, and they know how to use the system, and they use it. And so it's an incredible success. But we found that system fixes weren't enough. So the scheduling rates didn't increase. We didn't change anything about patient behavior with this process, and so we needed something more. So here are those numbers. So again, we have this great increase in referrals, but 50% of the patients were being booked. Some of that was logistical with, who was called, how they were being called, but we know a lot of it was that patients didn't answer the phone when we called, and they said, no, 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 no. And that's all patients. That's not just men. That's just those are the numbers for the whole population. And so I found that in terms of education, the only real education out there was bowel prep. So when you did get to GI, they would tell you how to take the prep and all about the procedure. That's the only consistent education I saw. We don't have any kind of patient reminders to tell patients, hey, you're due, call us, or we're going to call you. And again, the scheduling efficiencies were there. So we have this great success. What do we do now? Well, now we need to target patient behavior and see how we can change that with the right materials. And so what would you think makes a health message feel personal and relevant? If I was to reach out to a patient and say, hey, you should get this done, what do you think they would connect with?
If the doctor recommended it or a family member recommended it.
Right, family member recommends.
Someone important to them. So that's social cognitive theory, everybody.
Right back. So, about 6 months ago or so, I was in this class. I don't know how and why. I thought, a video would be great to address this issue. And I made the mistake of mentioning it to the marketing department about 2 weeks ago, and now it's happening. So I'm committed, but I'm very excited. We're all very excited to do storytelling. So one of the things that increases success of any health message is to have the people you're targeting in the video. We want to see ourselves. We want to be able to identify with the person speaking. We want to know that they have a real life like us. They have concerns, the same concerns we do. We want it to be in the language we speak. And so we're trying to hit all of that in this one video. And so last Thursday, we actually did our first testimonial with a patient who talked about how he was a no, 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 no guy. And he was like, I'm a man's man. That is not what I do. And he was really reticent about this procedure. But having the right friend tell him that it was okay and that it was going to be all right made him change his mind, and now he's the biggest advocate for the procedure. He gave us some really good information about how he says they don't tell us what it is, meaning he didn't know what happens. You talk about getting this procedure, what do you do? Because we all talked about how, for the most part, men really don't have to do screenings until they're 40. You get your blood pressure checked and your blood sugar levels, but you don't have any kind of screening. So you have someone who has not been to the doctor consistently and heard this message until they're 40, and now you're trying to get them to come in and do something invasive. So it was a really good conversation. And so yes, having a trusted role in his role model in his life really affected that. And so we filmed him walking the streets of Brooklyn so that people can identify. Luke has probably never seen himself on camera because the cameraman never gets in the camera. So yeah, Luke's in action there. Wanted people to really identify this is a Brooklynite who's just like you, who has the same fears as you, and he's okay. So the literature says that telling people they're going to die is not the way to do it. You should communicate that it is a serious illness that affects Black people particularly, but we can beat this. We can get screening. We can prevent this. We can treat it if it turns out to be positive. And so we're trying to hit all of these things that if you don't want the colonoscopy in the end, there is a stool test, and really communicate that there's something for everybody. Oh, this doesn't look okay. So when we create this video, we are going to have a Creole video, which I'm really excited about. And so one of our providers, I'm working with internal medicine, Dr. Garnier, will be speaking it, in Creole, and then also we will have it in English, of course. And so we're trying to represent the community. That's what we should be good at, right? We've been in this neighborhood. This is who we serve. We should look like the neighborhood and communicate to the neighborhood. So we're going to create this video, and it will be on the Downstate website as a YouTube video. And then we're going to share that at our health fairs and with other community partners so that they can help to educate their patients. At some point, I'll be working on reminders for the patients, to see how we can use. This is a digital campaign. So yes, we will have some paper, but we're really trying to reach the patients on their phones. We know that everybody's got WhatsApp. We know that everybody texts. And so we're trying to see how we can reach the patients that way. That's one of my roles here at Downstate is I manage digital innovation. And so I'm always trying to find ways that we can reach our patients that look like the rest of the world. And so I know that patients really appreciate a text and that calls them to action. We also want to do some provider training. So even though we see these patients, there's a way we should probably be speaking to our Black patients about colorectal cancer to convey the seriousness of it, and also particularly the Black men who are like, no, 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 right? I actually spoke to a person who said that if Capleton, who is a reggae star, said it was okay, he would do a colonoscopy. He would do a prostate exam. So I'm trying to get his agent so I can get him in the video if I can. He's a reggae artist, Capleton. Which one of these strategies you think? We'll find out later. So in terms of monitoring, we're going to be looking at clicks. How many patients clicked the text message, if I can get that data. How many people saw the video. all of the numbers. How are our screenings going, completed? What's the rate of completion of our screenings? Talking to patients about their experience, and all of that, qualitative surveys. We'll be doing all of that to track and see how this campaign goes. The hospital would like to share the video by next month, which is Colorectal Cancer Awareness Month. So we're super excited about that. So that concludes my presentation. If you all have any questions.
Probably a few in the chat.
Oh, I don't, okay, now we're gonna look at chat. Oh, it's right here. Okay. How often do patients have to get their screening? So it's once every 10 years, but if there's, any complication or the physician thinks that your history indicates more often, then you may have it, once every 5 years, once every 3 years. It depends on your results.
And then can you also comment on the colonoscopies every 10 years, but what if they opt for the stool test? How often do they have to do it?
Okay, so the stool test is every 3 years, because they are less reliable. So they're every 3 years.
Every 3 years.
Mm-hmm.
Hi, I have a question.
Sure.
Yes, so I know that I saw a picture, you said that you had someone advocate at barbershops, like talking to men, advocating about the health benefits of colonoscopy. Have you all thought of like churches as well? Because I know like there's a big influence in the church.
Yes.
And I know, specifically, I go to Seventh-day Adventist church, and I know sometimes we have like health Saturdays where they also advocate for these types of procedures to be done. So I just wanted to know, like, has there ever been any talk about, speaking in churches?
Right. That's the next step, is to connect with our community providers. And no, I have not done anything with the barbershops. That is the place to be. And that's where I have most of my colon chats with Black men. It's asking them, have you had your colonoscopy? And then this whole conversation. And so there's actually a barbershop I go to, and they said that they would support getting the word out. So there's a lot of potential here. The young man who we did interview and do the videoing, the filming last week, said that he would want his church in New Jersey to see this. So I think it's an easy way to get the word out that doesn't cost money in terms of paper, and people can get it on their cell phone and forward it to share. Is there any other questions?
So how many videos are you planning to produce?
So we don't want the videos to be any more than 2 minutes, which is the average attention span of all of us these days. And so today I realized there's we could probably, if Luke's up to it, we could do 7 videos out of the videos, right? So, it's awareness, the prep, just sort of, is there pain, right? So then people know, wow, when I go and click this is exactly the content I'm going to get. And so I'm thinking that's how we should do it, is to edit it so that they get a little bit of information at a time. And the message is, talk to your primary care doctor, talk to your physician about it.
No, that's excellent. I think it's it's necessary and required and low cost.
Low cost. SMS text messages generally are 8 cents or less per person, right? And back in the day, we used to send mail, and then they wouldn't open it. Mail's extremely expensive, and so we went a few years ago during COVID actually to the SMS text messages. And so
is there an effort to encourage, it's an automated referral obviously, but is there an effort to also encourage the primary care physicians to, raise awareness about this campaign, or at least show their patients that these videos exist?
Oh yes. So the clinic, we will have the QR code in the clinic. We will definitely have brochures, but the QR code has to be part of that. Physician training has to be part of this to advocate. And I think they need this. They need that kind of support, because how many minutes Dr. Duper talked about having 15 minutes to talk to her patients. So we need to support them outside of the office visit to increase these rates.
And Dr. Garnier is supportive of that?
Oh yeah. So I'm going to start with Sweet R, internal medicine, which Dr. Garnier is, and then all of the primary care areas. We'll start there. Yeah, spread it there. Yes.
It's gonna be a very interesting to evaluate that. This is excellent.
Yeah, we're excited, super excited. Yeah, and like I said, we had an excited testimony. He was excited.
So is that testimony done, the production?
That's done, and now it's in editing.
Okay.
Yeah.
So that's only gonna be 2 minutes?
Well, like I said, it's gonna have to be
So
10
that-
2-minute videos.
Was that a downstate patient?
He's not.
Oh, okay.
He's not. Like I said, have these chats, these colon chats, and someone referred me. So yeah, I was looking for a patient, but again, March is coming, so we wanted to go ahead and get it out. But yeah.
Yeah, I think you have another question.
I have another question.
The first question is, how difficult was it to get the volunteers to speak on camera?
Oh, he was easy. I was prospecting already because I had this idea in the fall, and then someone said, "Oh yeah, my friend was resistant, and now he's he's happy he did it." And I said, "Okay, put a pin in that. I may be coming back." And so I did go back and speak to him. I'm having these just a few hallway conversations, taxi ride conversations, and men they're hesitant, but I almost felt like they want someone to ask. He actually said, I sort of feel like people gave up on us. No one really talks to me about this, and feels like there should be a bigger emphasis on men's health. And so, that was insightful. But everybody's been very, very open about, well, I'll do the prostate/colorectal exam if it's a female, if it's a woman. A lot of them said that. I gave them the analogy of car maintenance, and I said, do you wait for the oil to burn black, or do you do annual? Oh yes, annual maintenance. They all got it. Yes, annual maintenance. I was like, so that really resonated with them, and I think it'll resonate in Spanish and Creole and right. So that's something. Yes, everybody. I couldn't even, finish the analogy before they were like, I got it. Yes, you're right. But yeah. I have another one. A buddy system. Our adult men to the buddy system. I don't know. I didn't ask about buddy system. So the question is, are adult men past the age of 50 open to having a buddy system to get past the fear of going to the screening alone? Yeah, I don't know if it's being alone or just don't want to do it. They just don't even know what the procedure is. They don't know that you just literally go to sleep and wake up, demystify the process. The gel being there when he got up, he's like, I didn't know that was going to be there. So we just have to be more clear. He asked about, he thought there was going to be blood. I was like, wow, I never even thought that would be, something that anyone would think about, but we need to be more expressed, give more express guidance about this is what is going to happen. So another thing we're going to work on is the bowel prep video. Not everybody is, 4th or 5th grade literate. So, pictures of, don't eat the rice, don't eat this, all of those things when it comes to bowel prep. I know a lot of us get the paper and turn it upside down, trying to make sure that we do the right thing. So imagine a patient who doesn't really read English. And so we're trying to address from all angles and give both primary care and GI alternatives that support the teaching that they're doing. So
Something about how did you decide your PCPs and GIs?
how do you decide?
So she means partnering PCPs and GIs.
Oh,
Partnering?
they're all here down.
They're here at Downstate. These are all staff at Downstate.
Thank you.
Okay, yeah,
They
they're all,
have to.
they gotta do it.
Because Dr. Garnier, you might mention Dr. Garnier is the chair, right?
Right. Dr. Garnier is the medical director of what we call Suite R for internal medicine. And so I worked with him and the other primary care PCPs to start this initiative. And so he's always on it to do the next step in the intervention and volunteer his area. Yeah.
Like he's not a GI.
No. So this is a primary care message, but GI of course is involved also. Yeah, so normally that's where everything starts. It's not that you have a bellyache and you go to GI. You go to your primary care doctor who helps you determine what the next step is, and if the referral is necessary, then you go to GI. So, do we have any others?
Any other questions?
All right. Is there another one?
I think, any other questions, you all? Anyone working on the EL colorectal cancer screening case study? No questions for Vikki? I know we have 2 sections. It was a very popular topic. Any questions about the intervention components? She had a great, okay, here, are women, here.
For sure.
Yeah, but your focus is on male.
Men. Yes. So definitely Black men and women are affected by colorectal cancer. And we just particularly niched down to men for this particular campaign. But for sure, it is the community that both genetically, Blacks tend to have more adenomas. We get them more frequently, so that means we need to make sure we're on top of that screening, because that is what becomes a cancer if it's not removed. And so we're trying to remove the barriers with more information. So outside of proposing stool testing and colonoscopy, are there any other interventions? Those are the interventions. Either it's a stool test that the patient does themselves, or they come in. I think there might be a scanned version, but that's kind of rare, and that's not what we offer at Downstate. But I suppose that could be done. But it's either one of the two. Yes.
What's like the current stage of the campaign and intervention right now? Is it just like involving more clinics in this campaign? Is it like just continuing with the clinics currently and trying to just increase the number of successful referrals for screenings?
So we just did the filming last Thursday for the young man who told us about his experience, and so we are actively building this video. Yeah, it's in process. And so we're hoping in the next couple of weeks to have the first version out. But we want to translate it into, we'll have Dr. Garnier present in Creole and dub the patient we saw in Creole. Yeah. And then ultimately, toolkit is my buzzword these days. I think to have a toolkit that says, here's how we would approach this population of patients to increase screenings, this video, these materials, this is the way you should be talking about it, and make those recommendations.
So like, if I could ask that.
Sure.
Is like the main intention in terms of like products produced by the intervention is just like you're saying, just like having materials to communicate with certain populations, like just going forward in the future? Or is it to like increase the number of screenings right now?
Oh no, the sustainability of this is there's a video, right, and that we are sharing that video in the daily workflow. So a physician in the office says, here's a QR code or here's the brochure. I recommend you watch this. When they go to actually see the GI physician, they can use these materials to educate the patients in GI. They can right now they are emailing the bowel prep information. They can email this now to the patient. The patient has it to refer to. It will be on our website. And we like I said, we talked about the community, giving it to the community. So maybe the recommendations change later, but right now this is something that's sustainable. And again, what's important is to have it part of a workflow so it doesn't get dusty somewhere in a corner. And I also manage the SMS text blast at Downstate, and so if there's a population of patients that need this information because they're due, I can send that out to them in a matter of 30 seconds. And then that's, a touch point for us to disseminate the information. Do you think getting family members educated on the process would help and encourage their male loved ones? For sure. For sure. Again, trusted figures, your family, that's important because when I had one of my taxi ride conversations, my question was, doesn't your family need you? What happens if something happens to you? How will your family live without you? That resonated. And so people need to understand it's not just about you, it's other people that you connect with. So this one also says, were there any notable differences in behaviors between different age groups within the target population, 40 versus, of course, yes, indeed. Thanks for the question. So the 45-year-olds have no idea they're supposed to be getting their screening. They are the no population. They don't even, like, why are you calling me? One of our health plans will segment, by health plan, it's basically the younger folks and the Medicare folks. And the Medicare folks always do the best. They come in, they get their screenings. The younger ones just don't have any idea because, you're young, you're strong. So that is a problem that we need to increase. So that's another target population. I think I got everybody.
There was also a question a little higher up about whether the referrals are getting increased within the downstate setting itself.
So the referrals that I showed you, the bar chart, should I go back to it? Okay, so this is within Downstate. This is within our EHR. Can they see? I moved that. So on the left side of the screen, that was like September 2023. That was the average number. It was about 50, 60 referrals in the EHR. After the intervention, it went up and it sustained itself. Now there are seasonal changes. So in December, everybody goes on vacation. You're going to have less than in May when everybody's getting ready for their summer and they're fixing everything. That's going to seasonally change, but the docs are consistently sending those referrals out. But the data I found was that only like 50% of them were scheduled. Okay, and at first I was like, oh, it's a scheduling problem. Yes, but it's also patients don't want to be scheduled. Patients don't want the procedure. And so we need to do a better job of reaching them and telling them how important it is, particularly in this neighborhood, that they come. So that's what we're trying to increase with this intervention, with the patient messaging. Do you use insurance to provide the interventions? Any barriers that the patient population is experiencing? Any other determinants that you're noticing other than poor health literacy? So at Downstate, we're dealing with a mostly insured population, but there are programs. There's a cancer screening program that we have that's, is it the city or the state? CSP, is it the state? It's a state program, I believe. And some of those dollars are federal, but they are able to provide patients without insurance the care, the screening that they need. So those barriers are kind of taken care of, and so right now we're focused on the health literacy. All right.
And I was wondering if the patient education itself, if it focuses on the symptoms or maybe like a risk assessment for people who might need colonoscopies before age 40?
No, right now we are focused on the eligible population, which is 45 to 75. That's where we are right now. We're starting from the baseline. What is colorectal cancer? Can you see colorectal cancer without a screening? Does it hurt to get a screening? We're dealing on that level at this point. One day we can move to risk factors, but that's where we are with this campaign, is trying to get general information out, general good information to dispel the fears and the myths and the mistrust.
Okay, any more questions? Awesome. Well, thank you so much, Vikki Small, for volunteering your time. And I'm glad all the class was able to gain be exposed to I think this is, very important and somewhat novel for Downstate. So I have a feeling that it will be impactful because, our baseline is nothing's being done, right? And if we just hold on to the statement that that the young man in the video mentioned to you about being neglected, that's powerful. That says we're not doing enough to reach that population as a public health community, as an academic medical center, as a medical community. Why does that perception exist, right? And so I'm very excited that you're working in this area. I think men's health in general needs more attention. And, we're very much looking forward to seeing the results of the campaign and, working with you to evaluate it, hopefully.